Hi, myself Dr. Sheena. So today we'll be dealing with yet another topic that is bleaching. So normally enamel is called as a bioglass. That is because it filter most of the natural colors of dentine and the refractive index of enamel is 1.62. So whatever light comes and hit the tooth, it have the capacity to deviate and some of them are absorbed. So this is a basic property of enamel. Right. So what happens is like normal color of teeth is like in primary teeth, it have a bluish white appearance. It is a slight bluish white appearance. Permanent teeth has a grayish yellow or grayish white appearance as you can see in the image. With age, there will be a yellowish discoloration. This is mainly because of the deposition of more of a dentine and their wearing of the tooth structures because of attrition, abrasion, abfraction and erosion. Right. Next is like what is tooth discoloration? And over a period of time, because of various multifactorial effect, the tooth often discolor. This is a common problem seen in both primary as well as permanent teeth. So, what is discoloration? Discoloration is change in any hue, color, or translucency of the tooth. This may be because of any etiological factor like food related or the restorative material which we place or the drugs or the topical systemic drugs which the patient take or because of the pulpal necrosis, hemorrhage, etc. There are a lot of reasons for tooth discoloration. And it is of two type. First of all, dentist related factors and patient related factors. Dentist related factors because of our treatment, because if we actually properly doesn't do a endodontic treatment, there might be certain pulp remnants which often induce discoloration of the tooth. Sometimes the intracanal medicament which we place might also cause the discoloration of the teeth, and the obturating material also might discolor the tooth. Restoration, the usage of amalgam. Often we know corrosion products leak out, and there is something called as amalgam blue, that is the discoloration of the tooth because of the corrosion product. Pins and post can also cause discoloration. Patient related factors are various diseases that is related to the teeth like amelogenesis imperfecta, dentinogenesis imperfecta, or some drug related aspect because they might have taken tetracycline, etc., because of pulpal necrosis. All these actually are the main reason for tooth discoloration. So, pre-eruptive causes and post-eruptive causes need to be known. So, talking about the pre-eruptive causes, first of all, there are various diseases like the hematological diseases like sickle cell anemia, liver diseases, syphilis, porphyria, diabetes are the diseases which commonly cause discoloration. Congenitally, we know that tooth-related like amelogenesis imperfecta, dentinogenesis imperfecta, erythroblastosis fetalis, all these conditions shows discoloration, enamel hypoplasia, and the usage of medicaments and the condition of fluorosis along with tetracycline can cause discoloration. And renal failure is another reason, malnutrition and vitamin deficiency is also reason for discoloration. Now, certain peculiar feature of peculiar diseases. First is dentinogenesis imperfecta. In dentinogenesis imperfecta, the tooth often show yellow or gray-brown color. You can see it is yellow or gray-brown color showing that it is dentinogenesis imperfecta. Amelogenesis imperfecta is having yellow to brown color. In fluorosis, it will have a yellow patch. It will have some opaque or hypocalcified structure like uh, view of the fluorosized tooth. Sulfur drugs have a black staining. Very important. If black staining is there, it shows that it is sulfur drug. Tetracycline can move from gray brown to yellow in color. Anacrosis show a brown color. Hyperbilirubinemia shows yellow to green color. And the last is erythropoietic porphyria shows a red or brown color. So these are actually the normal conditions where various color often is being indicative of a particular disease. Next, we know that when dental pulp is dead, there is sometimes it causes discoloration of the tooth. We have seen that patient might actually come after few years with the chief complaint of either discoloration, and if we ask that patient whether he had a fall or something like that, he might say that 5 years back he had a fall. So what is the reason for the discoloration of the tooth taking place? Dental pulpal death often lead to the effect on hemoglobin. What happens is like the hemoglobin get converted or split into hemin, hematin, hemosiderin, and hematoporphyrin. So it get converted into all these four. Hydrogen sulfide produced by the bacteria combined with these pigments and darken the tooth. So the bacteria come and act, it produces a hydrogen sulfide. The hydrogen sulfide combines with the products of the hemoglobin, giving them a darker appearance. So hope you understand. So hemin is very important. So these are the components that is responsible for the discoloration of the teeth. Tetracycline staining. It actually is seen in both the dentition. The dentine is more affected when compared to the enamel. So what happens? The chelation of the calcium in actually the tooth take place along with the tetracycline, forming a newer material, calcium orthophosphate. So this is the component that is deposited which causes the staining of the of the tooth. Very important. Which is a sensitive period for tetracycline. This slide is very important. For an primary dentition, for upper and lower incisor, 4 months in utero to 3 months postpartum is the sensitive period. For upper and lower canine, it is 5 to 9. Just the slight change about the upper and lower incisors. For permanent tooth, it is upper and lower anteriors is like 3 to 5 months to 7 years. So that is a time period where the tooth is actually very much sensitive. Usually, tetracycline is contraindicated till 8 years. That is the total number that you need to know, that is till 8 years. Now, what is the average dose consumption? Average dose consumption of 20 to 35 mg per kilogram of body weight per day. In a day, 20 to 35 mg per kg during tooth formation results in discoloration. And if the dose is more than 35 mg per kg per day, result in both discoloration as well as hypoplasia of the tooth. So if it is 20 to 35, just a discoloration of the tooth is actually seen. If it is more than 35, discoloration and also hypoplasia is also seen. Understood. So another classification is like intrinsic, extrinsic and internalized stains are also there. NATO's classification is very important. NATO's classification N1 is like color of the chromogens is similar to the dental stain. The tooth onto the tooth there are chromogens, color causing organisms or materials come and attach. So if it is having yellow color, the stain will also have yellow color. That is type 1 direct dental stain. Type 2 is like the chromogens after attaching to the tooth structure, it changes color. So the chromogen changes color after binding to the teeth. The first one was like chromogen and the stain had same color. Second, chromogen going and attaching to the tooth surface, it shows a change in the color. And third one is indirect method where the pre-chromogens bind to the tooth and there is a chemical reaction taking place leading to the staining. That is important. The chemical reaction is a term that you need to memorize. So what is the mechanism of bleaching? Bleaching is actually a redox reaction. Redox means it contains reducing agent and oxidizing agent. Okay, so this oxidizing and reduction leads to the formation of the redox reaction. So what happens? So there are certain terms that you need to know. In that, it is saturation point. What is a saturation point? We know that if we keep on applying a bleaching agent, there will be a particular point after which bleaching doesn't take place. That is called a saturation point. See, The whitening action slow downs beyond a point during the treatment that is called a saturation point. So even though we keep on applying bleaching agent doesn't mean that it keep on whitening the tooth. There's a particular point called as the saturation point beyond which bleaching doesn't take place. Now, what are the various bleaching agents? Hydrogen peroxide, peroxide containing bleaching agent, and non-peroxide containing bleaching agents are there. You can see hydrogen peroxide is one of the most commonly used bleaching agent, that is H2O2. So what happens is like it is again an oxidizing agent. Very important. The concentration ranges from 5 to 35. It is a clear colorless white colored material and it have a shelf life of about 3 to 4 months. We have to handle it very carefully. If we are not properly isolating the gingiva and doing bleaching, it might cause necrosis, slight irritations, burns, ischemia, etc. Okay, so this is what happens. You know that this is H2O2 is hydrogen peroxide. This gets splitted to form H2O plus and O plus. So what happens is like you can see these are the free radicals. H2O2 get converted to form free radicals. So this O plus is actually a weakened structure. It is not stronger. So what happens is like this weakened structure get buffered, so it get actually buffered. Next is the perhydroxyl group. This is the material that is causing the bleaching action. Very important. This is a material which causes the bleaching. So what happens is like we know that our tooth we'll be applying on the coronal surface. There are dentinal tubules. So what happens is like this HO2, the perhydroxyl group, enter into the dentinal tubules, and what they does is like they actually break down the double bond chain of the inorganic and organic material to single bond chain, and also there are like ring like structure. These are also disrupted by this perhydroxyl group. So what happens is like larger molecules are converted into smaller molecules, so the amount of light reflected will also be maintained as such, and the tooth become lighter. So this is actually the mechanism how which the bleaching take place. So H2O2 get converted into the perhydroxyl group. The perhydroxyl group is actually the most stronger thing that enter into the dentinal tubule. They remove all the double bond and single bond of the inorganic and organic matter. Larger molecules are converted into smaller molecules. Hence, the amount of light entering is reduced or absorbed is reduced. The tooth will look lighter. Next is the concentration of H2O2. There are different concentration of H2O2 that you need to know. First is like superoxide. As I said earlier, H2O2 is having a composition of 5 to 35% in between. If it is 30%, it is called a superoxide. Very important. If it is 30%, it is superoxide. If it becomes 35%, it is called as wideness HP max. And in between 33 to 35, lace peroxide acid. In this, the important is actually superoxide. So this was one of the questions that was asked for a NEET PG MDS. Superoxide is, so you know, it is simply a combination of H2O2 in distilled water, 30%. So this is the answer. The first one is the answer. Next is Meccan solution. What is Meccan solution? That is again a derivative of the hydrogen peroxide. It is actually a combination of hydrogen peroxide with hydrochloric acid. Very important. 5 part of H2O2 to 5 part of HCl and anesthetic ether form Meccan solution. This is also important as such as that of the superoxide which I have told. So Meccan solution is actually a combination of the H2O2, HCl and ether. Okay. Next is carbamide peroxide. So as I said, the most commonly used is hydrogen peroxide. And next is carbamide peroxide. These two are the peroxides. Actually, carbamide peroxide is similar to that of hydrogen peroxide, but it have an extra fitting called as the urea. So urea along with the previously seen hydrogen peroxide is actually carbamide peroxide. So simple. Earlier the concentration was about 35%. Here it is 3 to 45%. Right. And the most common and what happens is like it is 10% carbamide peroxide. When it break down, as I said, it contain urea and H2O2. It produce about 10% carbon peroxide, produce about 3% of H2O2. Very important. Hope you understood. Next is sodium perborate. So sodium perborate is not a peroxide derivative. It is another, it is a non-peroxide derivative. So a question might be like, which is a non-peroxide bleaching agent? It is sodium perborate. Very important, sodium perborate is a non-peroxide material. Now, these were the type of materials that I use for actually bleaching, mainly H2O2, hydrogen peroxide. Its derivative is urea being added to for carbamide peroxide. A material that is not at all a peroxide is like what? So, sodium perborate. Understood. Next is the various bleaching techniques. There are vital bleaching and non-vital bleaching. Vital bleaching means the tooth is live, but discoloration is there. The patient want a higher tone of color. So what we do is like two types are there. It is done on the outer surface. Think that since it is vital, we need to do in the outer surface. The first is in office. The patient will be coming to the clinic. We'll be doing there. First is like thermocatalytic vital bleaching. What is it? As the name suggests, in office, the patient tooth on surface will be applying the bleaching agent already we have studied and activated by a thermocatalytic agent, like a light is used for activation of the particular bleaching agent. Next is non-thermocatalytic bleaching agent means we'll be simply applying bleaching agent on the tooth surface without activation. That is non-thermocatalytic bleaching. Hope you understood. Next is dentist prescribed home bleaching. That means that we'll be allowing the patient to go home and use the bleaching agent in a tray. In a tray, they'll be applying the bleaching agent and they'll be placing in the mouth and they'll be sleeping. That is a night guard bleaching or home bleaching. There comes the next condition, non-vital tooth. The tooth is dead. So what we can do is like we can do the access opening and inside the tooth we can make a hole and we can place the material and activate it. That is thermocatalytic bleaching. And walking bleaching means we will be placing the material and closing the canal and the patient will be left. That is walking bleaching. The patient is walking along with the bleach within the tooth and he will be recalled afterwards. So thermocatalytic bleaching, as I said, it is a vital bleaching. You can see in this image, we'll be applying on the tooth surface and a light from outside will be actually used to activate it. So what is used in thermocatalytic bleaching? Very important. Normally, 35% of H2O2 is used in thermocatalytic bleaching. It is otherwise called as power bleaching. You know, certain power is actually used for activating the bleaching agent that is used on the tooth surface. So we can use either light or heat or a combination can be used. So the light commonly used are laser lights, light heat lamps, spirit lamps, polymerization light, bleaching unit, etc. are used. Next is non-thermocatalytic bleaching. So in thermocatalytic bleaching, we use 35% of sodium hypochlorite. So important, 35. When it comes to non-thermocatalytic, there is no light and all. So the material which we use is superoxide or Meccan solution we have already studied. This too is actually used in non-thermocatalytic bleaching. Thermocatalytic bleaching, just 35% of sodium hypochlorite. Here, the other two combination. Next is dentist prescribe home bleaching. Next, the patient is going to home. What we give them is like 10 to 15% of carbamide peroxide. Don't get confused with all these things. In clinic, we'll be dealing with only hydrogen peroxide. If patient is going home and doing the bleaching, it is otherwise called as night guard bleaching. We'll be giving carbamide peroxide. The patient will be actually using some trays like this. Into that, the bleaching agent is placed and we will be actually ask the patient to keep that in the night. Hope you understood. Next is non-vital bleaching. Very important. Non-vital bleaching means the tooth is dead, So we need to do a root canal treatment. See, in the first image, root canal treatment is completed with the placement of gutta percha inside that. So what we do is like we'll clean the coronal portion, and a small amount of cotton which is saturated with the bleaching agent is placed inside this, and on top of that we will actually close and seal the pulp chamber, and will leave the patient and is recalled. So what are the materials used in the walking bleaching? This is called as walking bleaching or out of office bleaching or home bleaching. Very important. In that 30% of H2O2 or sodium perborate and superoxide combinations are used. These are the differences that you need to keep in mind, right? So what are the materials that we used as a barrier? Whenever this is a root canal filling, we'll be placing a small barrier here on top of the gutta percha, because bleaching agent have the capacity to penetrate deep down, and it may cause a deleterious effect on the dentine like resorption, etc. So for preventing that, we place barriers like Cavit, GIC or MTA. This is very important. All these materials are placed on the surface of gutta percha to prevent the leakage of the barrier, leakage of the bleaching agent which we place on the tooth surface. The level of barrier should be 1 mm incisal to the CEJ. So this is a cement to enamel junction. It should be placed 1 mm below the CEJ. That is very important. Hope you understood these two important topics. The adverse effects of bleaching agent. As I said earlier, the bleaching agent moves into the cervical area through the dentinal tubules, and it might cause an inflammation in the periodontal space and activation of the osteoclast and the inflammatory mediators like PMNL cells, and it can cause cervical root resorption. This is one of the most important commonly seen problem. You can see in this image the area where we place this often lead to the cervical resorptions. Next is chemical burn. If we are not properly isolating the tooth and doing, it can cause tissue burns. And another important thing is like never use a composite restoration in a bleached tooth. That is because not for a particular that is for a particular time. That is because what happens is like whenever we do bleaching, there will be small amount of peroxide that is seen in the dentinal tubule. So when we apply a composite to that tooth and do a curing, it won't cure properly because it would interfere with the bonding agents. That is why bleaching of the restorative material, bleached tooth should not be given a composite restoration as soon, but it should be delayed to 2 to 3 weeks. Very important. And catalyst treatment is used, you can just memorize, we need not wait 2 or 3 weeks. Sometimes a catalyst material treatment at the first visit can actually remove the excess peroxide. So we need not wait for 2 to 3 weeks for the composite placement. Another treatment is sodium ascorbate. It is actually buffered with vitamin C that consists of 90% of ascorbic acid. So it also remove the excess peroxides that is actually seen in the tooth. So these two are very important treatment to the tooth, which can actually remove the excess hydrogen peroxide that is present in the tooth surface. So carbamide solution for bleaching degrade 2. It is 3% sodium hypochlorite. As I have already told, if we take 10% of carbamide peroxide, it gives 3% of hydrogen peroxide and the rest is urea. Understood. A 12-year-old patient come to office with a history of tetracycline use. The anterior teeth is having a yellow color. What method you would use to, because we know that there are two type of bleaching, in office and home bleaching. Tetracycline stains are, it's not a mild stain, it is a moderate to severe stain, so it need more of a exposure. That is why we will be giving at home bleaching agents. Next important term is microabrasion. Microabrasion is actually where we use a combination of hydrochloric acid, especially 18% hydrochloric acid with pumice. That is applied on the tooth for 5 seconds, and after that we'll be actually rinsing it. So what happens is like there will be microscopic layers of enamel is being eroded, and that in turn increase the tooth color. So that is the method. So it was actually found by Kroll. Kroll gave 18% of hydrochloric acid and pumice. We know that pumice is an abrasive, and hydrochloric acid also erode the enamel surface. So what happens is there is slight loss of the enamel, bringing the color back to its normal thing. This is another chart that you need to study. First of all, Kroll, now we have studied, Kroll gave microaberration. Microaberration is a combination of 18% hydrochloric acid with pumice. Next is carbamide burrs, very important. This was micro. This is macro aberration. This is not seen much, the first one. Second is like macro aberration. We'll be using a burr and we'll be slightly running through the tooth. So there will be removal of this thing. Now, Spasser is the person who find out walking bleaching, nutting the walking bleaching combination, Mackin solution we have already dealt with, thermocatalytic by Stewart, Highwood and Hyman is night guard bleaching, Rayton is laser bleaching. Just memorize the term, sometimes the question might be asked. So the question, Theodore Kroll in 1986 is associated with, we already know Kroll is like microabrasion. So what is microabrasion? Where we'll be using what? 18% of the you can see here hydrochloric acid with that of actually pumice. The first is the answer, microabrasion. So 12 fluted bar is like, it is macroabrasion. Okay, Dakin solution. What is Dakin solution? We already studied. It is sodium hypochlorite. So thank you. That was all the important topics in bleaching. Bleaching, especially tetracycline bleaching, fluorosis, what is the time period, various bleaching agents, what is the mechanism, redox reaction, hydrogen peroxide formation, each types which is used. Macroabrasion, microabrasion. That is actually the summary of this bleaching agent chapter. Hope you had a nice class. Thank you. See you in the next class. Bye.